Hello everyone. My name is Babi. I'm one of the ACCS acute medical trainees. And what I'm hoping today is I'm hoping to present a case to you that I found quite interesting. It's a patient that I saw on one of my acute medical takes. And I thought it would be quite practical and maybe useful. This is a case of Mr. JC. He's a 79-year-old gentleman. He was brought in by ambulance, and when you go and see him, he describes waking up in the morning, trying to mobilize to the toilet, and having this sudden onset central chest pain that he describes as a dull ache with associated shortness of breath. And then he's unable to recall the events afterwards. His wife found him sort of on the floor, unconscious, but breathing, and she called the ambulance. By the time the ambulance crew arrived, he's regained consciousness. In terms of past medical history, he's got mild COPD, he's got CKD, type 2 diabetes, hypertension, and a previous left total hip replacement several years ago. His drug history was sort of what you would expect. So he's on inhalers, he's on PPI, he's on bisoprolol, losartan, amitriptyline, allopurinol, and cholecalciferol. He lives with his wife. They're both very independent. He mobilizes with a walking stick, but he's got a good exercise tolerance. So he describes sort of going out for long walks along the seaside with his wife without having any sort of chest pain or breathing problems. So on examination from the bedside, he's alert and awake. He's slightly short of breath at rest, but he's not using his accessory muscles. He doesn't look cyanotic. He's warm and well perfused. He's got good cap refill. You listen to his chest and it sounds clear. His heart sounds were normal, and he's got no peripheral edema. You examine him thoroughly and he starts complaining of significant pain in his left hip, and he's unable to do a straight leg raise. His observations, his respiratory rate was 20, his SATs were 92% on air, his blood pressure was 143 over 101, and his heart rate was 108. This is his ECG. I hope it comes out clearly. So when I saw this, the only thing I noted was that he was slightly tachycardic. So he's got about 3 squares between, just underneath 3 squares between the QRS complexes. So it's just above 100 beats per minute. And he's got slightly sort of flattened and maybe even inverted T waves in lead 2 and lead 3. His blood results come back, and it shows you that he's got a troponin of 118 and a creatinine of 255. So he's got eGFR of 20, which is CKD stage 4. But that's his baseline when you compare it to all his previous blood results. This is his chest X-ray. So unfortunately, it's a slightly poor film because you can't see the left costophrenic angle. But there's no obvious consolidation. There's no barn-dorn signs of heart failure or pulmonary edema. This is the X-ray of his hip. So there's an obvious left periprosthetic hip fracture. So my first question would be, how would you treat this patient? So would you treat him as an NSTEMI? Or would you sort of delay ACS protocol and investigate this further? So would you do an ABG, a D-dimer, BNP, CTPA, CT autogram, or get an orthopedic opinion? So I'm sorry, I'm having to pre-record this presentation, so I will do awkward pauses in between, try and give you guys some time to think about it, and if you're feeling sort of brave enough, pop an answer on the system for us. So in A&E, he was seen by one of the A&E juniors, and he was started on ACS protocol because sort of the history, sort of fitted with cardiac sounding chest pain. He had a significant drop rise. He was referred to the orthopedic team and the medical team jointly, and he was seen by myself, actually. So I saw the patient and I thought, yes, this could possibly be an NSTEMI. The sort of loss of consciousness or the syncopal episode didn't really fit with an NSTEMI. So I thought sort of a differential diagnosis would be, is this a PE? So what I wanted to do was get an ABG, get a D-dimer, put the patient on a cardiac monitor. Could he have had an arrhythmia? And then organize a CTPA if the D-dimer was raised. So this was his ABG on air. So shows that he's got a type 1 respiratory failure with a PO2 of 7.9 and a low PCO2 as well. So he's probably sort of got a higher respiratory rate than what we first thought. His bicarb was slightly low. So he's got sort of a VQ mismatch because his chest x-ray looks relatively clear. I know he's got COPD, but it's quite mild. He sounds like he's got a good exercise tolerance. So it doesn't fit with a classical patient who's sort of got hypoxia because of chronic severe COPD. His D-dimer was over 3,000. Now, unfortunately, I didn't calculate a well score as I should have. So the question is this relevant, especially given that he's got a significant periprosthetic fracture, so you expect the D-dimer to be raised. D-dimers in the context of a without a well score is difficult to interpret. So my next question would be sort of, would you organize a CTPA? So patient's eGFR is 20. So you have to go and discuss with the radiologist regarding a scan. Your hospital, unfortunately, doesn't have the capacity to do a VQ scan. So would you strongly advocate for the patient to have a CTPA regardless of eGFR? Delay the CTPA, try and hydrate the patient, stop the nephrotoxics, wait for the eGFR to improve? Or would you perform sort of bilateral ultrasound scans of his legs to look for a DVT? So sort of my thought process with this was that he's got CKD, so it's unlikely that we're going to be able to optimize his renal function any further than what it is at the moment. It is at his baseline. You can consider organizing ultrasound lower limbs, but if it's negative, are you not going to perform a CTPA? And the other question is, if it is positive, sort of, would you not perform a CTPA? And so this gentleman needs orthopedic intervention. He might need general anesthetic. So I think it's important that we know if he's got a PE or not. I think overall, the risk of us missing a PE probably outweighs the risk of him developing contrast-induced nephropathy in this case. Sort of, you can probably have a whole presentation on its own on contrast-induced nephropathy, depending on who you speak to. Sort of, it's either a complete myth or it's a very, very real and significant danger. I think the answer is probably somewhere in between. We do have to recognize that there are patients who are at risk of developing contrast-induced nephropathy, and we should mitigate everything that we can do to reduce the risk of that. But I don't think, sort of, especially if we have a very significant suspicion of a diagnosis, I don't think we should sort of deprive patients of having the appropriate scan to get to that diagnosis if another scan is not available for us. So this was his CTPA. So I'm hoping you can see this, but there's quite significant pulmonary emboli pretty much in all of his main pulmonary vessels. So it was reported as bilateral multi-segmental pulmonary embolisms. So what would you do now? So would you give him treatment dose Clexane? Would you hold treatment dose Clexane because he's already had ACS treatment? Would you give him half the dose of treatment, start unfractionated heparin, or thrombolyze? So we opted to give him treatment dose Clexane. We adjusted the dose to 1 milligram per kilogram in light of his eGFR. Another option could have been to give him more fundaparanox. So the treatment dose for fundaparanox in P is 7.5 milligrams, depending on his weight. So if it's between 50 and 100 kilograms, it would be 7.5 milligrams. So we could have given him the extra dose there. I think sort of our priority was to make sure that we don't undercoagulate him. We may have overcoagulated him in this case. The other problem with him was that given that he's got the left periprosthetic fracture, he was in a lot of pain. So I don't know what you guys would have given him for pain relief. So sort of options here I put is regular paracetamol, paracetamol and NSAIDs, paracetamol and PRN Oromorph, or PRN oxycodone, regular morphine, modified release, or a fascia iliaca block. So we decided to perform a fascia iliaca block just before we give him the Clexane, or even sort of took him for the CTPA, because he was in quite a lot of pain and we had to sort of maneuver him to get him onto the scanner, and that would have been quite tricky. And then we prescribed regular paracetamol and PRN oxycodone in light of his CKD. So I've got his echocardiogram scans here, and just a quick recap on the basics of the sort of the four views that you tend to get, the basic four views of an echo. I'm not by any means an expert in this, so forgive me if I get anything wrong. So the four views that you tend to get is the parasternal long axis view, the parasternal short axis view, the apical four-chamber view, and the subxiphoid four-chamber view. And this diagram sort of shows you where you would put the cardiac probe, and the arrows are pointing towards where you would put the marker on the probe, where you would like it to point towards. So if we start off with the parasternal long axis view, I'm hoping this comes out clearly on here. So he's got, so if you see it, this is the left atrium, this is the left ventricle, this is the aorta, this is the mitral valve, and here would be the aortic valve. I can interpret this because I've seen the report, but they've described sort of a mild left ventricular dysfunction. And then if we go on to the parasternal short axis view, so this here is the left ventricle, and this is the right ventricle, and the right ventricle looks quite large, and there's also sort of flattening, slight flattening or bowing of the intraventricular septum. So this is suggesting that he's got right ventricular strain. And on here, you've got the apical four-chamber view. So this is left ventricle, right ventricle, left atrium somewhere here, and right atrium somewhere here. And as you can see, the right ventricle and the right atrium do look quite enlarged. And then lastly, this is the subxiphoid view. So here you've got the left ventricle and the right ventricle. And again, you can argue that the right ventricle looks slightly enlarged on here. The report says that he's got a dilated RV with flattening and bowing under intraventricular septum. So he's got RV strain and he's got mild TR. His IVC was non-compliant with respiration, suggesting that there is sort of an element of overload. And the overall impression was consistent with right heart strain and an acute P. So in terms of his further management, so we decided to admit him to CCU for close monitoring. He needed orthopedic input in light of his left hip periprostratic fracture. So we opted, along with the orthopedic team, to insert an IVC. I mean, if you read sort of the NICE guidelines, they sort of advocate against the use of IVC filters. But in this case, given that he had the hip fracture, he required surgical intervention, the risk of him developing DVT was quite high, and we wanted to mitigate the risk of sort of further demand and further clots forming, and also him having further Ps. We sort of intentionally delayed his operation for 5 days and continued him on treatment dose Clexane. There was a note that his hemoglobin dropped sort of on day 3, and the reasoning behind that wasn't entirely clear, but it was probably most likely secondary to the fracture. He was transfused 1 unit of red blood cells to try and optimize him for theaters, because we would aim for a HB of 100 in patients who are undergoing operation. On day 5, he had the open reduction internal fixation under general anesthetic and a fascial block. And then his Clexane was restarted 24 hours after the operation. He remained in hospital for a total of 16 days, and he was discharged home with package of care, and he was mobilized with his Zimmer. He continued on treatment dose Clexane for 6 weeks whilst the IVC filter was in place. The IVC filter was then removed, and he was switched to warfarin in light of his EGFR being 20. I know it sort of recommends that an EGFR of less than 15 we should avoid NOACs, and 15 to 30 we should use it with caution. But overall, in this patient, it was thought that it was likely that it would be in his best interest to be on warfarin rather than NOAC. He had a repeat echo in 6 months' time, which showed that his RV has gone back to normal size with a good systolic function. So sort of my take-home points from this, and what I decided to sort of further read up on, was sort of risk stratification and treatment in pulmonary embolism. So the European Cardiology Society put out guidelines in 2019. And I don't know if you've had a chance to read it. If you haven't, it's quite an interesting sort of read. I would definitely recommend it. And sort of the thought process that we had sort of in the past of sort of stratifying Ps in terms of large P or massive P and non-massive P, sort of they decided to use a different approach, which is stratify them in terms of low risk, intermediate risk, and high risk. And the way we do that is with various tools, including echocardiograms, the CTPA result, as well as blood results, and PESI score. So I'm sure you guys are all familiar with the PESI score. I'll put a brief diagram sort of explaining it here. And it is a very useful risk stratification tool. Just to be aware, it's only validated for stratification after the confirmation of P. I know we do use it to sort of risk stratify patients to see if they're suitable for ambulatory investigation, but it's not validated for that, just to be aware. So sort of this flow diagram I thought was quite useful. It made me think about how I treat patients with PE in a different manner, instead of going from sort of patients that we think are good and early discharge. It sort of starts us thinking at it from are they hemodynamically unstable? If they are, then we need to seriously consider reperfusion treatment. And if they're not hemodynamically unstable, then it recommends that we do a PESI score or an equivalent risk stratification score, as well as looking for RV dysfunction, so either an echocardiogram or a CTPA. If one of these are present, then it recommends us doing a troponin test. So if the troponin is raised, then it sort of considers that it's an intermediate high risk PE. And these are the patients that we need to really sort of be aware of, and they need close monitoring and even consideration of reperfusion treatment if they deteriorate. So sort of what is high risk PE? So high risk PE is PE with hemodynamic instability. Cardiac arrest, I would argue, is the most unstable form of hemodynamic instability. And then you've got obstructive shock. So the European Cardiology Society sort of defined that as a systolic blood pressure of less than 90, despite adequate filling. Sort of the caveat behind that is these patients have already got significant RV overload. They've got significant CCF. So we have to be careful in terms of trying to give them more fluid. The guidelines recommend sort of anything below 500 mils of crystalloid. And then if you start giving them anything above that, I think we might start affecting their preload, and we probably won't make any benefit in terms of their blood pressure. It also says that a blood pressure drop of over 40 millimoles of mercury for longer than 15 minutes can be defined as an obstructive shock if there is end organ hyperperfusion associated with it. And I found this diagram quite useful in terms of thinking about what is actually happening when these patients have significant RV strain. So if we go through it, sort of they have sort of significant RV afterload that causes dilatation, that causes activation of neurohormonal mechanisms, and overall, eventually, the right side of the ventricle fails, and then it starts affecting the left side. And I just want you to be aware, sort of blood pressure drop comes sort of almost towards the end of this cascade that leads to death. So it is a late sign, as something that made me sort of appreciate how unwell these patients are. So treatment for high-risk PE. So in a cardiac arrest situation, you would thrombolyze them. So the guidelines suggest that we make these decisions quite early. It's difficult. These patients don't tend to come in saying that they've got a PE and then go into cardiac arrest. So the history is very, very important. And also sort of this is where bedside echoes in cardiac arrest, if you've got the right technician, if you've got an expert, sort of very experienced technician, it can become quite helpful to look at the right ventricle. The dose of alteplase is 50 milligram as a bolus, and then if you give alteplase, the guidelines suggest that you carry on CPR for at least 60 minutes. If they're not in cardiac arrest, you would give them a 10 milligram bolus over 1 to 2 minutes, followed by a 90 milligrams infusion over 2 hours, and then start them on unfractionated heparin infusion afterwards. With thrombolysis, the risk of severe bleeding is 10%, and the risk of intracranial hemorrhage is about 2%. These are the contraindications, sort of the absolute and relative contraindications for thrombolysis. Just to be aware, sort of, I saw at least 5 or 6 different variations to this. What we have to be aware of is that the contraindications for PE is not the same as the contraindication for ischemic stroke or MI. These are the ones that I found on the guidelines from the European Cardiology Society. The other thing to be aware of is that, I guess, in a cardiac arrest situation, you can argue that these are not set in stone. Other treatment options available is if you're in a tertiary center, you can try and have a surgical embolectomy or percutaneous catheter-directed thrombolysis. So with intermediate risk PE, sort of the definition or the suggestion is evidence of RV strain without hemodynamic instability. These patients tend to have an elevated troponin or a pro-BNP, and on CTPA or an echocardiogram, there's evidence of RV dilatation. And if you look at the diagram here, sort of our patient had signs of RV dilatation, as in diagram B, C, and D. So treatment-wise for intermediate risk PE, so sort of, I think we're all familiar with how to treat sort of low risk PEs, and we're all familiar with how to treat high risk PEs. The intermediate risk PEs, there's been a lot of sort of studies, a lot of debate about how we should treat them. The biggest study that was done was probably the Petio trial back in 2014. So it's a trial that involved over 1,000 patients in sort of many sites, and they were looking at sort of death or hemodynamic decompensation within 7 days. And the overall result showed that there was significant reduction in death or hemodynamic decompensation in the patients that were thrombolized, but there was also quite significant risk of hemorrhagic stroke and also extracranial bleeding. And I think by extracranial, they mean anything out of the brain, so anywhere in the body elsewhere than the brain. They also wanted to look at whether it improved sort of morbidity if these patients didn't develop sort of chronic thromboembolism syndrome, and the evidence for that wasn't there in the study as well. So in terms of treatment for intermediate risk PE, sort of the European Cardiology Society guideline sort of suggests close monitoring because these patients are at risk of deteriorating, ideally in the CCU HDU setting. So treatment dose clexane. There is an argument to consider a BD regimen, so giving 1 milligram per kilogram BD instead of 1.5 milligram per kilogram once daily. And I guess sort of the rationale behind it is sort of the half-life for clexane. It's about 12 hours, so you would be giving them a full 24-hour cover if you give them a BD dose. And obviously sort of unfractionated heparin infusions, especially in patients who've got a very large BMI or are in end-stage renal failure. The guidelines also recommend sort of continuing low molecular weight heparin for at least 72 hours or until the patient becomes more stable, and also considering thrombolysis if patients become hemodynamically unstable. So the greatest benefit for thrombolysis was seen in the first 48 hours, but there is still effective up to 14 days. So back to our patient. Would you have thrombolyzed Mr. JC if his blood pressure dropped following diagnosis of PE? And the second question would be, would you thrombolyze Mr. JC if he went into cardiac arrest? So I couldn't find a straightforward answer for this. So he's got a periprosthetic fracture, so he's at significant risk of major bleeding. There's no specific guidelines for this scenario. The only thing I found is a few case reports of sort of successful thrombolysis in major trauma patients, and even one in a patient who underwent craniotomy 3 days prior. I don't know the answer. I need senior help. in a cardiac arrest situation, I think there'd be a strong sort of argument that you can thrombolyze this patient because sort of we're left with no other option. So my take-home message from this case was that personally, I think a good clinical history and examination was key. If I sat back and just looked at the blood results, you could easily argue that this patient had an ACS and you should treat him as such. And I think this is where sort of we need to realize that our history taking and our examinations should guide our investigations, not the other way around. I also realized the importance of risk stratifying these patients, especially patients with an intermediate risk PE, the patients that aren't hemodynamically unstable but are at significant risk of deteriorating. And also, is there an argument that we should consider doing troponin and BMPs in pretty much all patients who have PE to try and root out some more of these patients who are at risk of deteriorating? And then also the importance of making decisions early with senior help, sort of thinking about, is this patient for thrombolysis? Do they have any contraindications? What is their escalation of treatment? I hope that was useful. I'm sorry I'm having to pre-record this presentation, so I haven't had a chance to see any of your answers, but if you have any feedback, any thoughts, any questions, you can email me. I've put my email address on there, and I can ask one of my colleagues to pop the email address on the system. So thank you very much.